Hello, and welcome back for another affiliate-focused branch of the UF Care podcast, conversations with early career professionals studying addiction research here at the University of Florida, as well as providing advice and support for those entering the field. My name is Victor. I'm a fourth-year graduate student in the Department of Clinical Health Psychology, working with Dr. Jeff Boiseno. Today we are joined by Alleyne, a rising fifth-year graduate assistant here at the University of Florida in the Department of Pharmacodynamics, under the mentorship of Dr. J. McLaughlin. Hi, Amy.
Hi.
How's it going today?
Pretty good. How are you?
Good. I'm doing well. We were talking about how this is graduation weekend, so lots of parties and other things going on, but you were saying you had a different kind of plan.
Yeah, it's not graduation week for me just yet, hopefully soon. So I am planning to go downtown after we're done today and then probably lay some floors at our house.
Oh, that's wonderful. Some homework. That's great.
Yeah, good times.
Yeah. Amy, I was also looking at your CV, which you do have online, and I saw that you've had a pretty varied training history.
That's true.
I was reading, I found out what an aquarist is.
Yes, that's funny. Yeah. I was an aquarist assistant in Baltimore before coming here. So I went to UMBC in Baltimore. It's University of Maryland, Baltimore County. And I wanted to become a marine biologist. There was no marine biology degree, so I majored in biology, and I was a volunteer, an aquarist assistant at the aquarium in Baltimore for a few years. I actually got to feed the sharks, which was really fun. I fed a little cowfish. There was an electric eel that if you held the fish in the water, he would have to do a circle first, and then he could get the little fish, and that was great. I really enjoyed the aquarium. So, yeah.
That's adorable. I didn't know eels had such personalities.
Yeah, I think he had to be treated when he was younger, so they had him do that in a net so they could scoop him out of the water to give him whatever the treatment was, and then afterwards it just became a habit to do that. So,
the little squirrel.
Smart. Yeah,
yeah.
Smart eel.
Yeah, you've also been a physical therapy technician and a veterinary assistant, which is just so much.
So I didn't know what I wanted to do after. I wanted to do marine biology. I did the aquarist assistant, but all the positions were volunteer. So I actually taught scuba diving in Malaysia for about a year and a half. And then I enjoyed it, but wanted something a little more challenging. So I'd always been into fitness. So I thought I would try physical therapy. I was a personal trainer throughout that whole time, but I tried physical therapy. And since I had to pay for my own undergrad, when I learned how expensive physical therapy school was, and vet school, actually, that's when I kind of geared away towards those. But I tried both of them, and it was around then that I had gotten married, and my husband and I wanted to move somewhere warmer. He's actually from Trinidad. So we moved to Florida in 2017, and that's kind of how we got here. I started working for Dr. Eric Krause, and he was the one who was like, you should do grad school. So here we are. It was very roundabout. I actually didn't know I wanted to get into research until working with him. So
absolutely. It's really neat to hear how people find their way to the positions that they are in now. And if you could actually tell us a bit about what kind of work you're doing currently.
Yeah, for sure. So I'm in J. McLaughlin's lab, like you mentioned, and his lab is a pharmacology lab. So we work really closely with medicinal chemists. They make novel compounds, mainly focusing for us on chronic pain and addiction. When it comes to chronic pain, we are working with mice, and we try to see if these medications can benefit mice that are modeled from chronic pain diseases and are also not addictive. So we test to see if the mice seek these drugs out, if it causes them to have a decrease in respiration, which is common with opioids that target the mu receptor. So we test these different compounds and see if they could be potential candidates for further investigation that may one day end up in a clinic.
Absolutely. So the mu receptor, I'm trying to recall past conversations that I've had for this podcast. That's an opioid receptor, right?
Yeah. So there's three. There's mu, kappa, and delta, and they all have their pros and cons, but mu tends to be the one that's targeted in clinics for the treatment of pain. So when a patient is maybe given something as strong as morphine, that's mainly targeting the mu opioid receptor, and that's what helps us to decrease pain. Kappa also has benefit at reducing pain, but it has some negative side effects, so we tend to avoid kappa. But that's actually when it's centrally administered. So if you have kappa receptors that are active in the brain, you'll get these dysphoric effects. But we actually are working on a paper that shows if you target kappa in the periphery, so outside of the central nervous system, you reduce those dysphoric effects and can still get the benefit of reducing that pain that's being experienced. So overall, mu is the one that most people are targeting.
And you're working on exploring the mu receptor in mice currently.
Yeah, so that's what most of the lab is working on. I actually work on a different receptor that's called sigma-1. It's a little less known. Some people know about it, some people don't, but it's actually a really exciting receptor. And it's interesting because to define it as a receptor is something we debate in our lab a lot because it's actually a chaperone protein. But what's good about the sigma receptor, sigma-1, there's actually two, there's sigma-1 and sigma-2. My work focuses on the sigma-1 receptor, but it's a non-opioid receptor. So when we talk about mu and kappa and delta, like I mentioned, there's positive effects and there's negative effects. But sigma-1 is a nice new target because it's not an opioid receptor. It doesn't appear to be addictive. It doesn't have the respiratory depression effects that other receptors have, such as mu. It doesn't seem to cause dysphoria like kappa or seizures like delta. So the sigma-1 receptor is really interesting, and that's where my dissertation lies. So outside of the opioids, actually.
For sure. And just for folks who are listening, who are less familiar with the kind of terms used in this research, can you describe respiratory depression and dysphoria?
Yeah. So when we use drugs that target the mu opioid receptor, you get euphoria or a pleasurable effect. And that can be a big cause of why it's so addictive, because you're like, hey, that felt really great. I like this drug. I'm going to take more of it. With mu, though, we get something called tolerance, where you'll need a greater and greater dose, a higher dose, in order to feel the same effect. So mu will cause a happy, euphoric effect, but it causes tolerance, which is not good, and it can cause dependence. When we target kappa receptors, those actually have the opposite effects. So instead of feeling euphoria, where you're like, hey, this is great, you actually feel dysphoric, where you kind of will avoid. It's aversive. This drug is aversive. So you still might have a reduction in pain, but if you're not willing to take the drug, then it doesn't really help you. And then delta, I feel like delta is the ugly stepchild. Like we don't normally talk about delta. Delta opioid receptors can cause seizures. So that's the main reason we do not. Yeah, like of all the things, liking a drug, not liking a drug, and seizures, we normally avoid delta, but we do.
Absolutely. Delta. Okay.
Yeah.
So working with the mice as you are currently, what's the specific research you're looking into? What is for example, your hypothesis? What are you trying to find?
Yeah, so sigma is interesting. It actually, when you block sigma receptors or antagonize sigma receptors, there's a lot of literature that shows it can be beneficial at reducing the chronic pain. So if a person has chronic pain, you can reduce the feeling of pain, but it also can reduce feelings of addiction. So it can reduce drug seeking. In the context of opioids, biologically, and this is pretty interesting in my field, the sigma receptor can actually bind to the mu opioid receptor and reduce its activity. So if we block the sigma-1 receptor, we can let mu function normally, and we shouldn't need such a high dose of exogenous mu agonist like morphine. You don't need that. That tolerance won't occur maybe as fast. So sigma, if we can work with sigma and blocking sigma, we can hopefully reduce the amount of opioids we need to treat a pain patient. But my field actually, my dissertation looks more into psychostimulants. So methamphetamine in particular. There's also cocaine. But what's sad is that there's currently no treatments for psychostimulant use. So we have a lot of drugs that look at opioid use, but there's no treatments for psychostimulants like methamphetamine or cocaine. So our hypothesis based on other literature is that if we can target the sigma-1 receptor, we can hopefully find a therapeutic that might be beneficial at reducing psychostimulant use. And it works in a bit of a different way. It works at a dopamine transporter that we call DAT. So the dopamine transporter prevents there from being too much dopamine in your system. So when you feel happy, maybe you have some ice cream or some cake or something that makes you feel good, you get a release of dopamine. But your body's really good at pulling that back in. You don't want too much happiness about cake or ice cream, maybe. So these dopamine transporters will pull the dopamine back in, so you get a little happiness, but not too much happiness. But with drugs such as cocaine and methamphetamine, it messes with DAT and it keeps dopamine around longer. And there's been studies that show that the sigma receptor can actually promote a conformation of this transporter that allows that dopamine to stay around longer. So similar to the mu opioid receptor, if we block sigma-1, we can let the dopamine transporter function normally and bring the dopamine back inside in cases of methamphetamine and cocaine. So that's what I test in mice. And I do it both in vivo, so while the mice are alive, and also ex vivo after the mice are not with us anymore. So I'm combining these in vivo experiments where we actually give mice methamphetamine. And when you give them methamphetamine, they basically run around a lot. They're like, woo, methamphetamine. And then we also give them sigma antagonists, and we can see that reduction in running around like crazy. And then afterwards, I actually take the brain out and I use a technique called electrophysiology where I can patch onto neurons and listen to the neurons fire or communicate with each other. And in cases of just having been treated with methamphetamine, these neurons are firing really quickly. But when we give methamphetamine and a sigma-1 antagonist, the firing is actually significantly reduced, almost back to normal. So it seems like targeting the sigma-1 receptor could be beneficial as a treatment for psychostimulant use disorder. So I guess that's the hypothesis. Can we use sigma-1
oh my goodness,
to treat psychostimulant use?
Absolutely. And I will say that all sounds incredibly complicated and incredibly interesting. I think I'd have to listen to what you just said like 3 more times for it to start to sink in. Yeah, the whole
time I'm like, say it slower.
I mean, it's one big logic puzzle, right? This chemical does this to the brain, but this receptor can stop that chemical, but this other chemical can turn on this receptor that stops that receptor from doing, it's this whole big chain. And it sounds like you are sort of shifting through the data and trying to find out how these different signals and receptors and chemicals all interact to give us feelings of happiness in response to these addictive substances.
Yeah. So sigma-1, it's not all bad. I think of this a lot. Like we have stuff in our body because they're normally good for us and normally working for us. So sigma-1 actually, under normal conditions, it's almost like a tuner, like a volume tuner. So when something's wrong with your body, it's actually normally located inside your cell. But when something negative happens, it moves to the membrane of the cell and it kind of turns up and down different channels and receptors. So maybe it'll increase potassium channels, which will cause some inhibition, or maybe it'll decrease sodium channels. So it actually fine tunes these other channels to protect the cells. So in cases of stroke or ischemia, sigma-1 activation or agonism, which is the opposite of what we are looking at, can be really beneficial. It can be neuroprotective. In preclinical studies, it's been shown to reduce brain cell death in cases of stroke and ischemia. So sigma-1 isn't always bad, but we've just learned that when you give your body maybe a drug of abuse such as meth or cocaine or even opioids such as morphine, these sigma-1 receptors kind of become maladaptive. I don't think they know what to do with it. They're like, something's wrong, but we're not sure what to do. So that's when it's good to block them. So like you said, it's this investigation of trying to figure out when sigma's good and when it's bad, and can these drugs help when sigma becomes bad, and what are those side effects? And it's a whole puzzle. And I think it's like really interesting to figure out what that balance is.
Absolutely. So, Amy, can you tell us a bit about how you got into the depths of this sigma-1, like all this receptor research, and how you latched onto this idea or this concept as your dissertation?
Yeah, definitely. So I mentioned before I was starting with Dr. Eric Krauss, who's also in pharmacodynamics, and his lab does a lot of hypertension work. And he was a part of this collaboration looking into sigma-1. So it was a big group of different PIs across College of Pharmacy. So there was Dr. McCurdy and Dr. Krauss and Dr. Fraser and Dr. McGaugh, like a bunch of different professors. And Eric had told me about this option, like working with sigma-1, but he told me about how confusing sigma-1 is. He's like, sometimes it's inside cells, sometimes it's outside cells, sometimes. And I was like, that sounds so cool. And again, like with my past, I didn't know what I wanted to do. I was like, maybe vet school, maybe. And so when he told me about this problem, I think I just like solving problems. I was like, oh my gosh, that's so neat. Like we could try this and we could try that. So it's actually Jay's lab that does most of the sigma-1 work. So when I started grad school, I ended up working in his lab. I was hoping to look more into pain, but then the addiction aspect was so interesting. Like I mentioned with sigma-1 interacting with these opioid receptors and the dopamine transporter, and sometimes it's good and sometimes it's bad. So I kind of shifted over to addiction, and here we are.
Here we are. Yeah. And what's next? What are your plans for the future, Amy?
Yeah, so I'm hoping to graduate either this fall or next spring, and I'm wanting to obtain a medical science liaison position. So one thing I've learned from being in grad school is I really enjoy scientific communication. Every semester we have what's called Journal Club, where we'll present a different author's paper. So it could be from a different university, and you stand up and present it in front of a group. And in the spring, we have a research seminar where we present our own work. And also the college has different competitions where you can, compete against different grad students and present your data. There's a 3-minute thesis, which I also competed in. I really enjoy presenting my data. I like to communicate and to talk and to share data, and also to see how I can make it obtainable to others, using the dial reference with sigma-1, like seeing how you can take something complicated and make it understandable for someone else. So that's basically what a medical science liaison does. They work between doctors and researchers, and they share information about drugs to doctors, but not in a sales way, in a way that they can learn ways that patients can be benefited. Like, what do the doctors need to treat patient A that might be different from patient B, and how can the researchers provide that? So you're a liaison between these researchers and doctors. So that's what I think speaks my name when I think about what I want to do in the future.
Yeah, Amy, that sounds excellent. You definitely seem passionate about this kind of work. You are able to, talk about these complex topics in a way that is understandable. So I could see, you really thriving in a medical science liaison position. Best of luck with your next steps.
Thank you so much.
Absolutely. Was there anything else that you wanted to talk about or share with us today before we move on to our final question?
I guess one last thing that we're kind of doing with Sigma that's kind of neat. So like I mentioned, sigma-1 receptors move around the cell. So one thing we're working on is we're using really high-tech microscopes, and we've actually tagged the sigma-1 receptor with a fluorescent tag so we can see it moving in cells, and it's actually kind of working. So that's kind of been fun.
Wow, that sounds amazing. So you can actually see this receptor on the cell surface.
Yeah, well, we see it like inside cells, and it's always moving around. It's kind of hard to figure out where it is, but yeah. So we're actually applying, methamphetamine and seeing if we can get those little receptors to move. But it was a big, we weren't sure if it was going to work, and then it did. So we can see sigma receptors, and it's really exciting.
That is so neat.
Yeah, thank you.
Of course. So our last question today, that's how we end all these conversations. Amy, do you have any words of advice for other folks who might be listening and thinking, oh gosh, what she's doing is so cool. I want to do that someday.
Yeah, sure. So I think addiction research is really exciting and really needed, especially with psychostimulant use. The number of deaths has more than doubled since 2019. So it's super important to do this research. When it comes to sigma-1, I think there's a lot of potential with it as a therapeutic. But there's actually been a lot of pitfalls in my dissertation. I thought I'd see these really clear, perfect results, and that definitely did not happen. So I think for those who are excited about this or want to do it, you should, but just remember that things don't always work sometimes, and that's okay. Like you're gonna end up helping in one way or another. You're moving that bar forward, even if it's for the next scientist or the clinical community.
Awesome. Thank you so much for your time today, Amy.
Yeah, thank you. It's been great.
Absolutely. Take care.
Take care.
Of course, we also want to give thanks to the University of Florida Center for Addiction Research and Education, Dr. Oliver Grundman, Dr. Sarah Jo Nixon, Dr. Joanne Paris, and all of our mentors and future collaborators. Till next time.